Hello guys and welcome. So continuing our discussion about diuretics, this video is going to be about diuretics. I'm going to talk about the pharmacokinetics, the mechanism of action, the therapeutic effects and the adverse effects of diuretics. So let's start. First, let me mention the common types of diuretics available. So diuretics, there is 4 common types. We have the furosemide, which is also the Lasix, and we have the bumetanide, the torsemide, and the ethacrenic acid. So bumetanide and torsemide are more potent than furosemide, so more potent than the first one, the furosemide. The ethacrenic acid has more adverse effects, so more adverse effects. Now let's talk a little bit about pharmacokinetics. So when these drugs are taken by the patient, they would be first absorbed, and furosemide, so Lasix, would be 60% absorbed, while bumetanide, would have a higher absorption, so it would be absorbed by 100%. And that's why bumetanide would be more potent than Lasix, which is furosemide. Also, these drugs are going to go, after they get absorbed, they're going to go into different organs, and including the kidneys. They would go into the renal capillaries, beside the proximal convoluted tubules here. They would be flowing here, and they would be secreted into the proximal convoluted tubule from here. So they would be secreted, then they're going to flow in the filtrate into the lobe of Henle here. Then they reach the thick ascending limb of lobe of Henle. That's when they work. And if those drugs are taken orally, they would work after 30 minutes, and if taken intravenously, they would work after 5 minutes. Yeah. So now let's move to the pharmacodynamics, which is also the mechanism of action. So diuretics would block the NaKCl in the thick ascending limb of lobe of Henle. So when they move into the lobe of Henle until they reach the thick ascending limb, that's where the NaKCl transporter is here, and it reabsorbs 25% sodium and potassium and chloride, and diuretics would inhibit this cotransporter and would lead to losing 25 to 30% of sodium, and also the same amount of water, because salt and water move together. And also it is from here actually they lead to lose water, so water comes from here. So sodium, water, also potassium and chloride, and also they lead to losing magnesium and calcium. So magnesium and calcium would be also lost, and also would lose the hydrogen ions. this is one mechanism that they work by. They inhibit the NaKCl cotransporter in the thick ascending limb. The other mechanism is that they enhance the prostaglandin E2 and I2 synthesis. And when they enhance that, this would lead, the prostaglandin, as we know, would lead to vasodilatation. So this would lead to renal vasodilatation. And if there is vasodilatation in the kidney, this would lead to blood flow, increase in the blood flow to the kidney, so increase blood flow, and would lead to increase in the glomerular filtration rate. So increase glomerular filtration rate. And also this prostaglandin would work systemically, so we would get systemic vasodilatation, so systemic vasodilatation. And if we get systemic vasodilatation, this would lead to a decrease in the blood pressure. And those drugs would work even if the GFR, the glomerular filtration rate, is 10. So they work even if GFR is 10, which is the last stage of the kidney failure, which is called the end stage kidney failure. So they are very efficient drugs. They work very efficiently, and that's why they called the high ceiling diuretics. Yeah. So again, low diuretics inhibit the NaKCl in the thick ascending limb, and they also enhance prostaglandin E2 and I2 synthesis, which give us renal vasodilatation and systemic vasodilatation. Now for the therapeutic uses of these drugs. First, they are very effective in relieving acute pulmonary edema. And to understand this, let's first understand how acute pulmonary edema is going to happen. So we have lungs, and here, and we have heart, and the heart, as we know, this is the right side, so right ventricle, right atrium, and this is the left side, so left atrium and left ventricle. And we have the pulmonary artery, which comes from the right ventricle into the lungs here. One will go also to the other lung, and it would come back as the pulmonary veins into the left atrium here. And we also have the aorta, which comes from the left ventricle and goes into the systemic circulation. So systemic circulation, and come back into the right atrium here. Yeah, so if the left side of the heart is weak, so we have this side of the heart is weak, this would lead to the blood not being able to move or eject freely from the lungs into the left side of the heart. So would lead to the blood collecting in the lungs here. So in case of left side heart failure, so left side heart failure, this would lead to the left side unable to collect the blood coming from the pulmonary veins, and would lead to the blood congesting here in the lungs. Also, in systemic hypertension, this lead to vasoconstriction of the systemic circulation. So vasoconstriction of the systemic circulation, and this will lead to increase in the peripheral vascular resistance, and would also increase the afterload. So the left ventricle is going to be unable to pump blood because there is very high systemic peripheral vascular resistance, and would lead to blood also collecting in the left side and subsequently collecting in the lungs. Now, the blood that is collecting in the lungs would leak into from the pulmonary capillaries into the alveoli, and this would lead to acute pulmonary edema, and the patient would have difficulty in breathing and cyanosis, and this would need an urgent intervention, and that's when diuretics comes into play. So low diuretics would work here to decrease the volume, so decrease the volume of the blood, and would lead to decrease in the afterload. Decrease afterload. And they will also relieve the pulmonary edema by another mechanism, which is by vasodilation. So they would lead to systemic vasodilation through prostaglandin, as I mentioned earlier. So they would lead to systemic vasodilation and decrease in the blood pressure, and they would give us a relief to the pulmonary edema. And they also, interestingly enough, relieve the pulmonary edema through a third mechanism, which is through pulmonary vasodilation. Pulmonary vasodilation. This is to the capillaries in the lungs. They lead to vasodilation of these capillaries, and they would also lead to decrease in pulmonary hydrostatic pressure, and they would give us a relief to the pulmonary or the acute pulmonary edema. So again, they work by three mechanisms: by decreasing volume, by inhibiting NaKCl, as we mentioned earlier, and by making systemic vasodilation and pulmonary vasodilation. Now, they also work very well in the acute or chronic peripheral edema. They work through decreasing the volume, so decrease volume, and they also would give us systemic vasodilation, and those would relieve the peripheral, will give us a relief to the peripheral edema. They also work very well in the acute or chronic renal failure. And that's because they work even if the GFR is 10, which is the end stage renal failure. GFR is 10. Work even if the GFR is 10 to decrease the volume, because the patient with renal failure have high volume of blood because they can't excrete that. So those work very well to decrease volume, and also for kidney vasodilation, so renal vasodilation, that would lead to increased blood flow to the kidney and subsequently increase in the GFR. And those a little bit of GFR increase is very useful for these people who have acute or chronic renal failure. Now let's move on to hypertensive emergencies. So diuretics works in hypertensive emergencies, which means that the systolic blood pressure is more than 180, and if the systolic blood pressure is more than 180, this might lead to cerebral hemorrhage, which is very dangerous, cerebral hemorrhage, and also they might lead to encephalopathy, which is also very dangerous. That's why we would use the local diuretics to relieve those hypertensive emergencies. And they work by, again, systemic vasodilatation. So systemic vasodilatation to decrease blood pressure. And they also work by volume decrease, so they decrease volume, and this is also would give us a decrease in the blood pressure. Interestingly enough, they also work by decreasing the sodium, so decrease Na, and this will lead to blood vessels less sensitive to catecholamines, so blood vessels less sensitive to catecholamines, So we have a blood vessel here. The endothelium of this vessel, if there is a very high Na or sodium in the blood, this would lead to the blood vessels being more sensitive to catecholamines, which is the adrenaline and noradrenaline, which cause vasoconstriction. If we reduce the sodium through local diuretics, those would lead to the blood vessel less sensitive to catecholamines, and this would give us a vasodilatation and subsequently decrease in the blood pressure. So now for the hypercalcemia, they also work very well to relieve hypercalcemia, because as I said earlier, they inhibit the NaKCl here. They would inhibit this transporter, and we would lose sodium, water, potassium and chloride, and calcium and magnesium. And when we lose calcium, we would get the hypercalcemia relieved. Now moving on to the adverse effects. First, because they inhibit the NaKCl here, NaKCl transporter here, we would lose again sodium, water, potassium and chloride, and calcium, magnesium, and hydrogen. That's when they inhibit that, we would lose all of this stuff, seven ions. So if we lose the sodium, we would get hyponatremia. If we lose the water, if we lose more than enough water, we would get the hypovolemia. If we lose a lot of potassium, we would get the potassium depletion. If we lose the potassium and the hydrogen, we would get the hypokalemic metabolic alkalosis. If we lose a lot of magnesium, we would get the hypomagnesemia. Those all could happen because if we lose more than what we need of these ions. The second adverse effect here is that those drugs would give us hyperuricemia. Hyperuricemia is high uric acid in the blood. Now let's go back a little bit to when they secreted here. So they would go into the proximal convoluted tubule and they would be secreted here. And also we have the uric acid is also secreted through the proximal convoluted tubule too. And they would, the low diuretics here, they would compete with the uric acid to be secreted through the proximal convoluted tubule. And this leads to the uric acid being trapped in the blood, and this would give us hyperuricemia. And this would lead to the gouty attacks being more severe in patients who have gout. They also would make a disturbance in the glucose metabolism. So the low diuretics will lead to potassium depletion, so less potassium. And the potassium is linked to the insulin release. So if there is a little potassium, the potassium is essential for the insulin to be released. And if there is a little potassium, we would get also a little insulin. And this will give us hyperglycemia. Also, the potassium depletion would also affect the GLUT4. GLUT4 is make the glucose enter the cells. So GLUT4 here is a transporter that make the glucose here enter the cells. If the potassium is depleted, the GLUT4 is also going not to work efficiently. So this would be inhibited, and this would lead to the glucose trapped and not able to enter the cells, and would also give us hyperglycemia. Now, when the insulin and the GLUT4 and hyperglycemia state that we have, this would stimulate the liver to start the gluconeogenesis. And when the gluconeogenesis started, this would lead to the liver trying to utilize the lipids, and when this happen, this would give us hyperlipidemia. Now for the ototoxicity. So those agents, the low diuretics, also affect the ear. That's because the same co-transporter that is available or is present in the kidney is also present in the inner ear. And when this is inhibited by the low diuretics here, so low diuretics, when they inhibit that co-transporter, it would also affect the inner ear and would lead to disturbance in the hemostasis of the electrolyte. So disturbance electrolytes in the inner ear, and this will give us symptoms like tinnitus, inner ear symptoms, so tinnitus, also hearing loss, and also sensation of fullness sensation. And those symptoms would be more severe. So more severe symptoms if the patient was old age. So if the patient is old age, would be more severe symptoms. And also if the drug is used is itacaric acid, because itacaric acid would have more ototoxicity, and they also would be more severe if the patient is also administering aminoglycosides and antibiotics. So aminoglycosides, because those drugs are also ototoxic. When they are also given with the low diuretics, this would lead to more severe symptoms, and maybe even this might lead to irreversible hearing loss. So irreversible hearing loss. And now finally, these drugs, the low diuretics, also might cause hypersensitivity reactions. That's because their chemical structure is similar to sulfonamides. Sulfonamides are very famous for causing hypersensitivity reactions, and low diuretics are also too. And they might cause symptoms like rash, or maybe immune reactions, like this might lead to anemia or thrombocytopenia. They might even cause something very severe like Stevens-Johnson syndrome. So Stevens-Johnson syndrome. So that's it for this video, guys. Thank you for watching, and stay tuned for the next week. We are going to cover thiazide. Yeah, so see you next week. Peace.